So when we talk about disruption in healthcare, this is nothing new. We do this every single day. We try and disrupt things and find where the value is. And whether we talk about, healthcare or healthcare, we have to put things in context. And we heard a lot of speakers, and I will take exception to some of Mitch's comments earlier. I don't know if he's in here. But, being an orthopedic surgeon, the parts are interchangeable. We don't care. And at our shop, it's very simple. We have all 36 joint replacement surgeons, and we all get convergence on what we do. Whether it's our notes, the implants we use, or the post-op protocols, it's all the same thing, and we've driven this over years. Because it's very simple. When we would go to administration and say, do we have a choice? They say, yes, you always have a choice, because we're on one-year contracts. So not much has changed since this was on the cover of Modern Healthcare over 15 years ago, talking about whether it's Alphabet Health, it's mHealth, iHealth, eHealth, whatever it may be, it's not the technology that we need to be concerned about. On the provider side, this is often the big problem with the focus is, what's disruption, what's mHealth? They talk about being mobile. Well, what's mobile? It's not necessarily using your phone. It's, can you do something somewhere other than in front of a physician, a nurse, or other healthcare provider? It doesn't matter what the device is. What matters is, what are you trying to do? And it's not just a matter of outcome and being any landing you can walk away from. I can replace almost any joint that you put in front of me from a knee perspective. But what I tell the 87-year-old who's a vasculopath, who's had 6 MIs, is that I'm not sure the engine's going to run when we're done. So, like this Iberia aircraft, you want to know what's going on. And one of the advantages we have in our shop is we are all full-time employees, and we do act as a unit because that's what we've done for years. So the organizational structure is actually, I think, more important than talking about some of the supply chain issues, because you've got to build coherence and how do you align everybody. And then you can use the technology to support what you're doing. Because the real challenge, no matter what we're doing, is to have the lowest cost and the best optimal outcome that we can possibly find for what does that patient want. Because it's not, the joint may look great on an x-ray, but if the patient's not happy, it doesn't matter. We know that a good 20 to 30% of total joint patients are just not happy. Does it matter which joint it is? No. Does it matter which surgeon it is? Could be. Does it matter what the system is you use to treat them? Do you send your folks to rehab, or do they go home, and do they know where they're going before you even schedule the surgery? So non-compliance is actually a shared responsibility, because if I don't explain it well, how can the patient be compliant? How do they know what needs to be done? And then if they go to the ER or they have a reoperation, then we've lost all the cost. And by the way, this is not the right way to look at it. We should invert this and really be talking about value. Where's the value being provided? And so whatever technology we're looking at is, how am I going to use the technology to manage a process? There's all these new toys in the OR. How many surgeons in the room? Anybody? Okay, so we got a couple. It doesn't matter what technology you put in the OR. It absolutely makes no difference whatsoever. What makes a difference is if you have 6 joint rooms, and I'm not always in room 37, then why aren't the rooms all the same? So we spent 10 years and many millions of dollars making all 6 joint replacement rooms absolutely identical. So if a nurse is going and reaching here, it's going to have the same things in every room. And that has driven efficiency, efficacy, outcomes, lower complications, lower problems more than anything else. So you have the inputs, the processes, and the outputs, and then the feedback mechanisms. This is where the technology can be helpful to either speed up a feedback loop, or to run the processes more efficiently and more effectively. How do you get results to your docs? Is it going to their iPhone? We have 7,000 iPhones. You can get the results on your iPhone. How do you get in touch with somebody? Something as simple as, do you publish the phone numbers of all those iPhones somewhere in a directory where everybody can get access to it on the web or on your mobile phone? So all of this technology feeds into what we have as our orthopedic continuum of care. And I'm not going to go through this in detail, but it starts when we set the expectations of the patient and go through it. So what technology can we give the patient, or what technology do they have to access it? Pre-op teaching, all online. If they don't have a computer, how do we get something to them where they can get that? And they can make an appointment to go in to any one of 30 locations in Northern Ohio to get it, or do it from home on their own computer. And then as soon as we do the left knee, of course, what are we thinking of? It's sales and marketing. Got to do the right knee. So you always want to be thinking about what's the next joint to do. So the steady state care in the community, how do we make the connection? And we're going to hear from, this is the 3J mobile health panel. You're going to hear from my partners in crime about all the different centers and steady state care, the episodic care, if you go to the hospital or surgery center, and then what happens when you go home? How do we connect you once you're home as well? These are the places that are ripe for disruption, and extending the care environment to the home is a huge area. How about connecting the various players and the stakeholders through secure communications? The Office of Civil Rights can walk into your facility, to your office right now, if you're a doc or a hospital, and literally say, if you have an iPhone, they can say, can I please see that? And if you have a text going outside your organization, or frankly, it depends on your network. If you have emails going to patients that aren't initiated by the patient, these are all things that can cost you a fair bit of money right now. So we have to look at the continuum. We have the IT infrastructure at the Cleveland Clinic to support all this continuum across all the different areas. So the referring physicians, for example, get access to the patient's EMR for 185 days through our Dr. Connect portal. Getting second opinions and removing the geographic barriers to care need to be there. And some apps can be on an iPad, some can be on a phone, some can be on a computer, some may need to be on paper if somebody doesn't have a computer. What if there's a language problem? So when we set all this up, we need to look at this, and it's been done in other industries for many, many more years than we've done it in healthcare. So we take a lot of lessons, certainly from aviation. But just remember, you may have the greatest technology in the world, but if you don't think about the processes, it will cause some sort of pain somewhere else. Now, I will leave you with two technologies that I've come across in the last few years. The team at Doc Sparrow, which I'm part of, has set up basically a secure communications platform that has passed all sorts of security audits so that the reps can get and find out what cases are scheduled so they can have all the supplies there. Because often, even though you have a huge inventory, something needs to be supported for the case. And you can't really go repless very easily unless you have this and let them know what the cases are. They've designed this on the front end for the physicians, mainly on the orthopedic side, but also on other procedures like cardiologists. So now the rep has secure access. It's actually all in the cloud, not resident on the device at all. And so they've been very successful in getting this out, and they've got about 3,000 orthopedic surgeons using it, and actually sending cases, case sharing network now. And what's nice is that you don't have to worry about HIPAA because it's a closed network and everybody's vetted on it. So everybody on the network, when they sign up, takes their own responsibility. You shut the phone off, or you leave the app, or it logs out on you, and nothing's there. So this is an example of mHealth technology that solves a business function for communicating. What am I doing on Monday in the OR? Like a first case, I need almost everything for that case is going to be on the shelf except two parts. But those two parts aren't available anywhere in Northern Ohio. They have to be sent in from the manufacturer. So these become important issues. And then also share with you another company that is started, which is extending the care environment from the episodic care for seniors into the home, looking at how do you get the family engaged, how do you get the patient engaged, and what's nice is that it's a simple plug-in to their existing TV. And what we found out about seniors is that almost all of them have a TV that's relatively new, or the families are actually willing to go out and get it because then they can do video conferencing, they can hook up with their providers. And so this has been interesting, and I'm not going to it in great detail, but these were two examples of how this is mobile, and this is on the TV for grandpa, but then, who makes all the healthcare decisions for the parents? Oh, which of the kids? Right, the daughter. Absolutely. So the daughter can have it on her phone and literally call grandma, grandpa, instantaneously and find out what's going on. So I just want to start on the provider side that, the whole mHealth explosion or any of the alphabet health issues are really not the technology. It is the business process.
Let's start with a story. And the story was not about creating a company. It was not about creating an mHealth company. In fact, we began the company before mHealth was even a term, back in 2004, 2005. It was set out to solve a problem. Right, our founder was a practicing endocrinologist at the Joslin Center for Diabetes at the University of Maryland. And she had two problems, right? One was that anybody who came into her clinic couldn't remember data, couldn't remember information. So they bring in their logbook. These are all type 2 diabetics. And she would say, gosh, what happened 3 weeks ago on a Saturday? I see your blood sugar spiked. Well, they couldn't remember what they had for dinner last night, let alone what happened 3 weeks ago. And more importantly, she would give them instructions, and they would go home, and they would lose those instructions. Or even if they had those instructions, they wouldn't understand them in the context in which they were living their life. And so Suzanne set out to actually solve her own clinical problem, not set out to, and we surveyed the world at the time, back in 2004. And there were companies like eSan and T Plus Mobile and Be Well Mobile, and they were all about moving data from one place to the next. They weren't about taking that data and turning it into something else. And so we cobbled together some small assets with Nokia, Johnson & Johnson, LifeScan, and we did a small clinical trial, 15 patients in the control group, 15 patients in the intervention group, and for 90 days. And we set out actually just to prove that people would use a mobile phone, a data-enabled phone, and I'll give you a sense of history in a moment, to communicate and to get information. And lo and behold, after 90 days, we showed a 2.03 drop in A1C. When you consider the average diabetic therapy, the average diabetic device gets about a 0.9 drop. We were twice as effective as the next best therapy or device. Published in Diabetes Therapeutics and Technology. And at the time, we got a lot of criticism. And the main criticism we got was criticism that said, I'm not sure people want to use data applications on cell phones. 2.5 years before the iPhone, we did this, right? 2.5 years before the iPhone. And when we began the company, if you look back at our slides from 2005, you'll see we had two simple ideas, and we all said that if we couldn't accomplish these two ideas, we would go home and we'd quit our jobs and go do something else. And that was improving outcomes and reducing healthcare costs. Well before accountable care, well before Obamacare, well before mHealth, well before the alphabets of health. And so I share that with you just as a sense of history. Where are we today? What is WellDoc today? WellDoc today makes the only FDA-cleared, clinically validated. We had a second clinical trial that we did a year long because people said to us, well, that was a small group, a small cohort. How do I know it'll work in a commercial environment? How do I know it'll scale? We got criticism about that. So we did a year-long clinical trial in and around Baltimore primary care docs and repeated, had a 1.9 drop in A1C after 12 months. So we make the only FDA-cleared, clinically validated, prescribable, and reimbursable mobile application. So for the first time in US healthcare history, it's hard to get your head around it because we live in this app world and it's ubiquitous and we don't quite articulate and understand it this way. We make the only mobile application that a doctor prescribes and a patient uses, and it gets reimbursed just like any other drug or device, no different. And as we've gone around this journey, we've had some interesting observations. As late as kind of 3 or 4 years ago, we would still get criticisms that says, okay, how do I know when, and we don't have, back then we didn't have Bluetooth technology where a glucometer would speak to your cell phone, so people were manually entering their data. And as late as 2 or 3 years ago really, people would say, that data is unreliable. You're having the patient input the data. How can I rely on this? And we would say, well, wait a minute, you relied as a physician on a patient who came in with a logbook. You didn't call that unreliable. And now we're enabling it through technology. It becomes unreliable. Well, you fast forward to today, right? And now if you pay attention to the market, patient-reported data is a godsend. People are yearning for, and that becomes the basis. So we think along a simple continuum, and that is taking data, turning it into information, knowledge, action, and ultimately outcomes. And as we think about healthcare today, and we thought we were early 10 years ago, although we didn't think we were early 10 years ago, it turns out in retrospect we were way early 10 years ago, right? And we kept thinking every year, we're still just a little early, we're still just a little early. I spend my time, other parts of my time, looking at the landscape beyond diabetes and mobile health technologies. And we're still early in diabetes. If you look at across the landscape of COPD and CHF and oncology, it's really, really early. And so what are we today? We're not a mobile health company, we're a healthcare company. It's not about, back again, as I said, mobile health didn't exist as a term. We set out to create a healthcare company. And we're also a behavior change company, right? The one thing that people said to us, they said, well, how do you believe you're going to take this fancy app on a phone and all of a sudden you're going to have a non-compliant, stubborn is what people used to call them, stubborn type 2 diabetic, and all of a sudden you're going to change outcomes. And what we found, it was all about that lack of information, that lack of knowledge, right? And so we've used tools, and again, we're device agnostic. You may have seen or read about, we did an experiment with Ford and putting our software in the InSync system. because we want to fit into your lifestyle. It's not about the technology. It's about how we change behavior. So imagine you wake up, your blood sugar is low. The system tells you the 15-15 rule, you drink some orange juice. You're running late for work, so you run out the door, you turn on your car, and the car says, well, wait a minute, 12 minutes ago your blood sugar was low. Are you safe to drive? Right? That's the world we envision in terms of the use of technology. So it's not technology for technology's sake. It's about getting the data and information and knowledge to people so they can take action, they can drive outcomes. And it works on both sides. It's both the patient side, so our system has a patient coach, real time, 24/7. It's behavior, motivational, and clinical. It's not all about blood sugars, carbs, and insulin and medications. It's about behavior. And then we have a second part, which is what we call our smart visit back to physicians. So through some of our clinical trials, we've shown that, and I think the founder of Iona Health had talked about this, they have 7 minutes with their patient. They got primary care docs that have very little training on diabetes. They don't understand the disease. Insulin is a very powerful, deadly drug. And so in our clinical trials, doctors were 5 times more likely to titrate a patient's drugs using the insights that we gave them. We don't practice medicine, but we take our analytics engine across the data that we receive, and we give insights into the patient that the physician can choose to ignore or follow. And so we're really facilitating that dialogue that occurs in a 7-minute, 4 times a year visit, and extending that clinical voice, that yearning that Suzanne had from the beginning, right? How do I get better information about my patient, and how do I extend my clinical voice so I can help them as they go through their day and manage this chronic condition that's very, very complex. So I'll stop there and let Jeff talk.
And I'm a family physician, and I was the vice president of health innovation for Walgreens, one of 5 or 6 physicians who worked for Walgreens. And you think, wow, how, 27,000 pharmacists. No, we're not ready for that yet. Wait. Stealing my thunder there. And, we have 27,000 pharmacists. And if you think about that, 27,000 pharmacists, we have 7 to 8 million people a day who walk into Walgreens. 7 to 8 million people a day walk into Walgreens. The pharmacists in general, don't like their jobs. We call it lick 'em, stick 'em, and count by 5s. They're very good at counting pills. They don't like that. And why don't we change that world a little bit to have them become really part of the healthcare delivery system? They went to school 5 or 6 years. They're smart as hell, most of them. Some of them aren't, I'm just like anything else. But most of them are smart as hell, and they want to interact with patients. And why can't they interact with mHealth devices like this? Why can't they do all kinds of different things? We also have over 450 clinics with nurse practitioners. So we already have clinicians that have the potential to be able to extend out. People talk about doctor shortage, which is our last conversation. I don't think there's going to be a doctor shortage. I really don't think there's going to be a doctor shortage. I think everybody talks a lot about it, but I think things are going to be done differently in the future. You don't need a doctor to do an ear infection. Third-year medical student, honestly, I hate to say it, probably can handle most ear infections. Maybe not all, but maybe 80 or 90% of them. Nurse practitioners for sure can do it. There's no question about that. And what is mHealth? And everybody says, oh, mHealth is cool, it's sharp, it's all this kind of stuff. But what will it do? Well, I think the issue is medicine, in my eyes, is mediocre, very mediocre. And people get mad at me when I say that, particularly doctors. But if you think about it, 50% of diabetics aren't in control, 50% of hypertensives aren't in control, 60% of the asthmatics aren't in control. And we have this great system that we can do great surgery, and I'm not faulting that at all. But if you think about it, if we could control the chronic diseases, we wouldn't have a healthcare crisis economically. It would be over. If everybody used a system like this, and what the issue is with mHealth in my eyes is not mHealth and this device is cool or that device is cool or whatever. It's everybody can do what they want to do. It's very similar to me to what happened with the apps with the iPhones. Why iPhones get crazy almost when they first came out? Because everybody's phone, everybody in this room, whether you have an iPhone or you have the Androids, is different. Mine is different than his. I customize my phone different than his. I think the same thing can happen in medicine. very easily, where mHealth devices, so this person with hypertension might take this device, or that device, or the third device. Who cares? Because right now, they're not listening to doctors. They are not listening to doctors, or doctors aren't talking to them, or aren't interested, one or the other. So the opportunity for mHealth, in my eyes, is huge. Then the issue is, all right, what you're going to do with the mHealth, and how's it going to occur? And honestly, I had one of the best jobs in the company, 240,000 employees, and I think I had the best job, because I looked at 300 to 400 new companies a year to see if we could integrate. If any of you heard about, as a perfect example, so it's easy to say because I can talk about it, is Theranos. Theranos is the one with the little blood through the finger instead of the venipuncture. 4 years I worked with Elizabeth. Elizabeth is the CEO. If you want to read something interesting, go look at Fortune magazine. You know,
Great article.
I worked with her, for Elizabeth, for 4 years to develop the relationship, and that's mHealth. That is mHealth. 50% cheaper. 50% cheaper, which is really where we have to be, and better quality, equal to or better quality than anybody else, which is, when you think about it, sort of mind-blowing, honestly. And that's where medicine has to go, and we have to be innovative and do things in that manner. So I want to just show something. Instead, I won't talk. I'll talk less. But I think this gives an idea of where things can go. And this is not here yet. So this is coming.
Nights when nothing should have gone wrong, since the next day was very important to me. So I took a quick shower, a really quick shower, and we both went to bed. But then, just when finally we were deep asleep, oh yeah,
Can we take that point around?
So obviously Tom had other plans for us. So I rushed to Tom's room. I looked at Tom. He didn't look well. So I touched his forehead. He was hot, really hot. So I pulled out my Tidal examiner. Oops. No, it's too early for that. So I took a thermometer. Wow. I better get Debbie. Deb, can you come here for a second? Honey, I think we need to take him to the clinic again. The clinic? No. So eventually I took Tom to the clinic. We had some traffic going. Serious traffic. I mean, real serious traffic. So we got to the clinic, and all I could think about was germs. I thought, I need luck to survive this place. Hello? I've been here forever. Mr. Marsh, it's you again.
Now he's going to stick this thing in my mouth, and then he'll tell me to breathe deep until I hear me faint, and then...
Okay, Mr. Marsh. In the end, it'll probably be... It's an ear infection, just like last month. But hey, what if we do it differently? Everything. I need a fast backwards here. Now, get to the part where he is reaching for the Tidal device. Introducing Tidal, a unique handheld device enabling anyone, anywhere to perform accurate physical examinations and remote diagnosis by a primary care physician. Tidal is personalized, intuitive, and safe, so that no special training is needed. Tidal can be applied anywhere, at home, at the office, or on the road. Tidal's unique navigation and guidance capabilities allow either remote online examination by a physician or self-examination while guided by Tidal itself. Both options ensuring high-quality readings and easy diagnosis by any primary care physician. Okay, so I see Tom has an ear infection. I suggest you get some rest. I will forward you a digital prescription shortly, and we can chat again if needed in a few days. Tidal, because healthcare can be that easy, accessible, and accurate.
Pretty powerful. Pretty powerful. Every mother who's seen this that I've showed this to said, oh my God, where can I buy it? Every mother I talk to. This is going to be, when it comes out, this will be, in my eyes, one of the best baby shower gifts you'll ever find. Because it also has a thermometer in it. So you won't have to buy a temporal artery scanner that's advertised like crazy.
But Jay, does it the knee range of motion?
Yeah. The reality here is this is mHealth. The world is going to change, and the world is. Do we need all the doctors that we have to see ear infections, or even nurse practitioners to see ear infections? Probably not. 2 o'clock in the morning, who wants to take a kid out? 10 o'clock in the morning with a kid with 103 temperature. Do you want to take them to the doctor's office? Nobody does. No mother wants to do that. What do I do with the other kid who's small? You know, how do I get to the doctor? Who's going to take care? All those issues can change. And medicine has really had troubles in regards to innovation for a long time. But we're at a time where medicine is saying it's time to innovate, which is great. for whatever reason, maybe the cost, whatever it is, we're at the right time. And things like this are going to occur, and mHealth, I think, is going to play a big role in the future, dramatically. And I don't think we have a clue where it's going to go 5 years from now. But it's not going to be 10 years from now. It's going to be 5 years from now. It's going to happen soon in my eyes.